Welcome to this educational video on gestational diabetes, best management principles. My name is Dr. Miranda Balgold, and I am a fifth-year endocrinology resident at the University of Toronto. My co-author for this presentation is Dr. Philip Siegel, who is an endocrinologist at the University of Toronto. We have no conflicts of interest for this presentation, and we would like to thank Dr. Fagg and Dr. Donat, as well as the Endocrinology Obstetrical Family Medicine Working Group at Mount Sinai Hospital for their comments and input on this presentation. The target audience for this presentation is all members of the healthcare team who care for pregnant patients with diabetes. This is an educational video and is not meant to replace clinical judgment or guide individual patient care. The objectives for this video are for you to be able to perform a clinical history to differentiate gestational diabetes from pre-existing diabetes, including type 1 and type 2 diabetes in pregnancy, to understand the importance of treating hyperglycemia in pregnancy, labor and delivery, and postpartum, and to be able to apply these key management priorities of gestational diabetes in pregnancy, labor and delivery, and postpartum, including the use of oral agents, insulin, including how to use it and how to adjust it, as well as hypoglycemia management. The key reference for this presentation is the Diabetes Canada Clinical Practice Guideline, which was most recently updated in 2018, with a focus on the chapter on diabetes in pregnancy. Here's the link as well as the reference. So first, diabetes in pregnancy. What are the different categories? A patient may have pre-gestational diabetes and now be pregnant, and this can include type 1 diabetes or type 2 diabetes. Or the patient may have developed diabetes in pregnancy, and this is diagnosed as gestational diabetes and is diagnosed in pregnancy. In terms of how to identify the category of diabetes in pregnancy, the first question to ask is, was the patient diagnosed with diabetes before pregnancy? If the answer is no, then most likely the patient has gestational diabetes. Albeit there are exceptions to this, and sometimes women are diagnosed newly with type 2 diabetes early in their pregnancy. If the answer is yes, they were diagnosed with diabetes before their pregnancy, then they have pre-gestational diabetes, and this can include either type 1 diabetes or type 2 diabetes. In terms of how to differentiate between type 1 and type 2 diabetes, there are several different clinical clues that can help you determine this. The first and most important question to ask is ask the patient, as they may be able to tell you what type of diabetes they have. Other things to think about are with type 1 diabetes, most of the time they would have had diabetes from before their pregnancy. They're very often on insulin since the time of their diagnosis. They may be on an insulin pump, and they may have a history of diabetic ketoacidosis. All patients with type 1 diabetes are at risk of developing diabetic ketoacidosis. In terms of type 2 diabetes, most often it's diagnosed in adulthood or can be diagnosed earlier. Most often began before pregnancy, or as I mentioned before, is sometimes diagnosed early in pregnancy before gestational age 20 weeks. They may have been on oral medications and or insulin prior to their pregnancy, and they may be on oral medications such as metformin and or insulin in their pregnancy as well. So a patient on metformin, that is a clinical clue that they may have type 2 diabetes, although there are exceptions to this, and sometimes diabetes medications such as metformin are used for other indications such as polycystic ovarian syndrome with infertility. So it is important to ask the patient why they are on the medications they are on. Why is it important to address diabetes in pregnancy? It's important because it's common. Up to 20% of pregnant women will develop gestational diabetes. And untreated diabetes and high blood sugars in pregnancy are related to adverse outcomes for both mother and baby. Early on in pregnancy, at conception and first trimester, so this would be pertinent for women with type 1 and type 2 diabetes or a pregnancy. Early on in pregnancy, there is a risk of miscarriage and malformations. Later on in pregnancy, in the second and third trimester, and this would be pertinent for all pregnant women with diabetes, including gestational diabetes, type 1 diabetes, and type 2 diabetes, there's a risk of macrosomia and the associated risk of C-section, shoulder dystocia, and birth injury. There's also a risk of stillbirth, neonatal metabolic complications at birth, including neonatal hypoglycemia, as well as preeclampsia. And it's important to recognize and treat diabetes in pregnancy, as we know that while there's an increased risk of these adverse pregnancy outcomes, treatment reduces these adverse pregnancy outcomes. For the rest of this presentation, we are going to focus on gestational diabetes. First, what are the risk factors for the development of gestational diabetes? These include an age above 35 years, being from a high-risk group, use of steroids and other medications that are associated with insulin resistance, pre-pregnancy obesity, pre-diabetes, which is also sometimes called impaired glucose tolerance, having a previous history of gestational diabetes in a previous pregnancy, having previously given birth to a baby that weighed over 4 kilograms, having a history of polycystic ovarian syndrome, having a family history of type 2 diabetes in a first-degree relative. Next, we're going to talk about how gestational diabetes is diagnosed. All pregnant women are screened at gestational age 24 to 28 weeks for gestational diabetes. And the screening test is a 50-gram oral glucose challenge test. There's a recommendation to screen earlier for previously undiagnosed overt diabetes if the patient is high risk. High risk features include a family history of type 2 diabetes, high risk population, pre-diabetes, previous history of gestational diabetes, age above 40, previously given birth to a macrosomic infant, or medicines that are associated with insulin resistance, including corticosteroids. Now, the screening test for gestational diabetes is the 50-gram oral glucose challenge test. How this is done is that the patient is given the 50-gram drink of the oral glucose challenge test. And after it is given, the blood sugar is measured 1 hour later. If the blood sugar is less than 7.8, then that is normal and the patient does not have gestational diabetes. If the blood sugar an hour later is between 7.8 and 11, this is a gray zone. And the recommendation is to then go on to do a second test. And that second test is the 75-gram oral glucose tolerance test. And then there's further criteria there for that test for the diagnosis of gestational diabetes. If the 1 hour blood sugar for the 50-gram test is above or equal to 11.1, then the patient has gestational diabetes. Of note, this is the preferred approach for screening and diagnosis of gestational diabetes. There is also an alternative approach, which is outlined in the Diabetes Canada guidelines. Next, we're going to talk about the treatment of diabetes in pregnancy and the targets for treatment of diabetes in pregnancy. Of note, these targets for blood sugars in pregnancy are lower than the targets for blood sugars for patients who are not pregnant. And also of note, the targets for blood sugars in pregnancy are the same for all patients who are pregnant and have diabetes. This includes patients who have gestational diabetes, type 1 diabetes, as well as type 2 diabetes. The targets for blood sugars in diabetes in pregnancy include a fasting blood sugar less than 5.3, a 1 hour postprandial blood sugar less than 7.8, and a 2 hour postprandial blood sugar less than 6.7. Why do we use these targets? It's because we have evidence we know that the complications increase above these levels. And you may also be asking, why are we measuring postprandial blood sugars? It's based on the studies and the evidence that we have, as well as convention. Next, we are going to outline the management of gestational diabetes throughout all phases of pregnancy, antenatally, intrapartum and labor and delivery, as well as postpartum. First, we're going to talk about antenatal management, and the keys of management of gestational diabetes in the antenatal period include measuring and monitoring capillary blood glucose, fasting and after meals, diet, as well as oral medications and insulin. First step of the management of gestational diabetes is to monitor capillary blood glucoses. These should be monitored 4 times a day, fasting as well as after meals. This can either be done 1 hour after meals or 2 hours after meals. At our center, by convention, it's done 2 hours after meals. And once again, these are the treatment targets: fasting less than 5.3, 1 hour after meal less than 7.8, and 2 hour postprandial less than 6.7. The next step to management after teaching and monitoring capillary blood glucose is to discuss lifestyle, including diet and exercise. The nutrition goal is to promote normal blood sugars and appropriate weight gain, and also to provide adequate nutritional intake. How is this done? It's very important to have a registered dietitian that makes a meal plan with and for the patient. The principles are to have a low glycemic meal pattern with a distribution of the carbohydrate intake over 3 meals as well as over 2 or more snacks, with a recommendation of one of the snacks being at bedtime. Low calorie diets as well as ketogenic diets are not recommended in pregnancy. And also physical activity is encouraged unless there are obstetrical contraindications. After diet and lifestyle, the next steps that are talked about are either oral agents or insulin. Sometimes there is a discussion of both, or sometimes the decision is made to go straight to insulin. In terms of oral agents that are used for gestational diabetes in pregnancy, these can include metformin or glyburide, with glyburide generally being considered third line. Metformin can be considered as an alternative to insulin. There is data for safety in pregnancy and some data that there's less maternal weight gain and less neonatal hypoglycemia. However, it does cross the placenta and use in pregnancy is off-label, and long-term data is insufficient at this time. Glyburide, the use of this oral agent in pregnancy is off-label, but there's evidence that suggests it's safe and effective in pregnancy. It does cross the placenta, and it's generally considered third line after insulin and metformin. Next, we're going to talk about insulin, which is a mainstay of the treatment of gestational diabetes. Before we go into the specifics for gestational diabetes and how to titrate insulin, we're going to talk about the types of insulin and how they're used. So the first category or type of insulin is basal insulin. This is sometimes also referred to as long-acting insulin or intermediate-acting insulin. And patients or other healthcare members may also refer to it as nighttime insulin, as that's often when it is taken. How it works is that this is background insulin. It keeps the blood sugar stable when a patient is not eating. It's usually given IHS at bedtime. Sometimes it's given twice a day in the morning as well as at bedtime. It's titrated to target the fasting blood sugar. So for example, if the patient's on Lantus at bedtime, which is a basal insulin, it's titrated up until the fasting blood sugar in the morning is in target. Examples of these types of insulin include glargine, which is brand name Lantus, or Detromir, which is brand name Levemir, and these are both long-acting insulins that generally don't have a peak and last for almost up to 24 hours. Another type of basal insulin is intermediate-acting insulin. This is Humulin N or Novolin NPH. These two insulins last for a little bit, not as long as the Lantus and Levemir. The other type of insulin that is used is bolus insulin. This is also referred to as rapid-acting insulin or mealtime insulin because that's when it's given. How it works is that its onset is fast and it has a quick peak, so it covers the meal and the carbohydrate intake during a meal. The onset is within 10 to 15 minutes. It peaks at an hour to an hour and a half and lasts 3 to 5 hours. It's usually given with meals 3 times a day, or sometimes a patient might take it once a day with their largest meal. And how it's titrated is it's titrated to target the postprandial blood sugar for that meal to be in target. And examples of this type of insulin include Humalog, NovaRapid, or Apidra. Next, we're going to show a graphic just to explain these insulins a little bit more. So first, the basal insulin, which is the long-acting or intermediate-acting insulins. This is the blue line here on the graph, showing that it's the background insulin that keeps the blood sugar stable and in target in the morning. And here is an example of an insulin pen, a pre-filled pen that a patient would use to give themselves this insulin. And then once again with the same graphic, here we're going to talk about the bolus rapid-acting insulin. These are the green peaks that are given 3 times a day with the meal. And this insulin helps cover the carbohydrate intake for that meal so that their postprandial blood sugar is within target. And here's another example of a pre-filled insulin pen that a patient would use to give themselves this insulin. Now, when insulin is started in pregnancy, we know that the insulin doses will need to be changed throughout the pregnancy. Insulin requirements increase throughout pregnancy, and this is due to the increased insulin resistance with pregnancy. The insulin resistance with pregnancy is complex, but is felt to be due to different factors that are produced by the placenta. Next, we're going to go through a patient logbook and to talk about some of the principles of insulin titration. The principles is when there's a trend that we can see that for more than one day there is a blood sugar that's above target, that's a trigger for us to know that the insulin needs to be increased. So here is an example patient logbook. At the bottom of the logbook, here we have a week from Monday to Friday, and at the bottom here are the targets. As a reminder, fasting less than 5.3, and 2 hours after meals, the target is less than 6.7. And we see here on the notes that to start off with, the patient is taking NPH 4 units at bedtime. Sometimes the patients would circle what blood sugars are out of target, or when you are looking at the logbook with a patient, you can circle the blood sugars that are above target. So looking here at the fasting blood sugars, we see that there's 3 days in a row when the fastings were above the target of 5.3. And as such, on Wednesday, the decision is made to increase the NPH from 4 to 6 units. And with that increase, the blood sugars are in target. If the fasting blood sugars continue to be above target even despite having this increase, then that would be a trigger to then increase and titrate up further. Looking at all the breakfast blood sugars, they are within target, as well as the lunch. We see that there's one at dinner, which was above target, but the patient noted that they had a higher carbohydrate meal at that time. And as this is not a consistent trend, we would not make a change and start insulin with dinner yet, but continue to monitor. Here is another example patient logbook, once again with the targets at the bottom. Starting off, the patient's on Humulin N, 10 units at bedtime, and Humalog, not taking any insulin with breakfast, but taking 4 units with lunch and dinner. Looking at the fasting blood sugars, they are all within target, so no change in the Humulin N at bedtime is needed. Looking at the breakfast blood sugars, 2 hours after breakfast, there's 2 that are above target in a row. So based on that, the decision is made on Wednesday to start Humalog 4 units with breakfast, and then after that, the blood sugars are in target with breakfast. Lunch, the blood sugars are within target, and at dinner, we see that 3 out of 4 for those 4 days are above target, and as such on Friday the decision is made to increase the Humalog with dinner from 4 to 6 units. Next, we're going to talk about the management of hypoglycemia. Before we talk about that, what is hypoglycemia? Hypoglycemia is defined as a capillary blood glucose less than 3.8. Symptoms of hypoglycemia can include hunger, sweating, lack of coordination, pallor, irritability, as well as sleepiness. And the goal is to quickly detect the low blood glucose and to increase the blood glucose to a safe level, which is 3.8 or higher. Here is an algorithm to outline the management of hypoglycemia. The first question is this severe hypoglycemia? And severe hypoglycemia is when there's a low blood sugar and decreased level of consciousness or seizure. If the answer is yes, then this is a medical emergency and you should call for help, get IV access, and give IV dextrose, a full amp, which is 50 milliliters of D50W stat. If there's no IV access, it may be necessary to give IM glucagon. If the answer is no, this is not a severe hypoglycemia episode, the next question to ask is the patient NPO? If the answer is yes, then it can't be treated orally and needs to be treated with IV dextrose. Depending on how low the blood sugar is, that tells you how much IV dextrose is necessary. If the blood sugar is between 2.2 and 3.8, half an amp, half of a pre-filled syringe of D50W, which is 25 milliliters, can be given IV. And if the blood sugar is very low, less than 2.2, 50 milliliters of D50W can be given. What is very important is to check the blood sugar afterwards to make sure that it is increasing. The recommendation can include checking the blood sugar within 15 minutes or sooner if the blood sugar is very low, less than 2.2. If the blood sugar is still low, then it may be necessary to give more D50W, and also a recommendation that if you're unsure what to do next, to call for help, for example, from endocrinology. If the patient is not NPO, then the best way to treat hypoglycemia is with oral dextrose. Usually this is given in the form of juice, 175 milliliters. And once again, it's very important to check the capillary blood glucose after the hypoglycemia is treated to make sure that it is indeed going up. So to check within 15 minutes or sooner if the blood sugar is very low, less than 2.2. If it's still low, give more juice, and also see if you should call for help, for example, from endocrinology for advice and management. After the hypoglycemic event is treated, it's important to think about why did it happen. It may be a unique situation. For example, the patient took insulin for their meal but missed their meal or ate less for one reason or another. If that's not the case, if it's not a unique situation, if it's recurrent or severe, it may be necessary to reduce insulin doses. And if there are decreasing insulin requirements, you may need to think about placental insufficiency as the cause. We know that there's a lot of things that happen for patients in hospital that can affect their blood sugars. This can include being made NPO. When a patient is NPO, more frequent capillary blood glucose monitoring is recommendation. And for patients with gestational diabetes, when they're not eating, their sub-Q insulin is stopped. Patients with gestational diabetes may also be given steroids for fetal lung maturity, such as betamethasone, and we know that steroids increase insulin requirements. So if the patient is already on insulin, we expect that they're going to need more insulin for the 5 days after they are given the betamethasone for fetal lung maturity. For example, for this patient, they're on Humalog 10 units with meals and NPH 10 at bedtime. The recommendation is to gradually increase up, first by 25% on day 1, and then day 2 and day 3 to increase all of the insulin by 40%, and then to slowly go back down so that by day 6, usually the patient is back down to their pre-steroid dose of their insulin. Next, we're going to talk about the in labor and delivery intrapartum management of gestational diabetes. And the key management principles for this phase of pregnancy include capillary blood glucose monitoring every hour, to target the blood sugar within 4 to 7 to reduce the risk of neonatal hypoglycemia. And if the blood sugar is consistently above 7, to then start IV insulin to reduce the risk of neonatal hypoglycemia. In labor and delivery, the goal is to target a blood sugar between 4 and 7. These are different than the targets that we talked about for while a patient is pregnant antenatally. Why do we have this target of a blood sugar between 4 and 7 while a patient's in labor and delivery? It is to avoid maternal hyperglycemia as well as to avoid maternal hypoglycemia. We avoid maternal hyperglycemia in labor and delivery as it is associated with a risk of neonatal hypoglycemia. It's related to the fetal exposure of high blood sugars in pregnancy and delivery. Glucose crosses the placenta, so when blood sugars are high, there is more glucose crossing the placenta, but the maternal insulin does not. So the fetus, in response to these high glucose levels, makes more insulin, and then once they are born, there's neonatal hypoglycemia. Here we're going to outline the key management principles of gestational diabetes in labor and delivery. Firstly, capillary blood glucose monitoring should be done every hour. And the target is a blood sugar between 4 and 7 in labor and delivery. Subcutaneous insulin is stopped for patients with gestational diabetes when they're NPO, as they're no longer eating. If the blood sugars are above 7 in labor and delivery for 2 consecutive hours, then the recommendation is to start IV insulin. If the blood sugar is above 7 for 2 consecutive hours, IV insulin is started. IV insulin is made out of regular insulin, which is mixed with D5W and is run as per a nomogram. It's usually run with D5W at 50 milliliters an hour, and this is run so that there's IV access and for safety in case there's a hypoglycemic event. Here is an example nomogram for IV insulin. In this nomogram, you can see that for each range of a blood sugar, there is a insulin dose in terms of units per hour that it is run at. And it also gives you the infusion rate, which may be different based upon how the insulin is mixed with the IV fluids. Of note, if a blood sugar is above 11 on this nomogram, that's outside the range of this nomogram, and the recommendation is to increase the IV insulin to 1 unit an hour and to notify the physician, as this may need to be increased even further. Next, we're going to talk about the postpartum management of gestational diabetes. The principles for postpartum management including recommendation for breastfeeding, to discuss the risk of type 2 diabetes, and to screen for type 2 diabetes with an oral glucose tolerance test done between 6 weeks and 6 months. Here we're going to outline these management principles. Firstly, breastfeeding is encouraged as it can help promote maternal weight loss. Capillary blood glucose monitoring is no longer necessary postpartum for patients with gestational diabetes. At our center, we measure it for 1 day fasting and postprandial breakfast the day after they deliver, just to make sure that we're not missing new diagnoses of type 2 diabetes that were misdiagnosed as gestational diabetes. There's no capillary blood glucose targets for postpartum for gestational diabetes, as they no longer need to check. There's no further treatment needed postpartum, and all insulin and oral diabetes medications that were started in pregnancy are stopped postpartum for gestational diabetes. And what's most important is postpartum care and follow-up, with a discussion that there is an increased risk of type 2 diabetes, and to screen with a 75-gram oral glucose tolerance test 6 weeks to 6 months postpartum, and discuss healthy lifestyle factors including diet, weight, as well as exercise. The key messages for this presentation is that the key first step to diabetes management in pregnancy is to recognize the type of diabetes, whether or not it's pre-existing diabetes, such as type 1 or type 2 diabetes, or gestational diabetes. To recognize that glycemic control and blood sugar targets are important in pregnancy. They're important because titrating to target can help reduce the risk of complications to mother and infant. And there are targets for blood sugars in pregnancy as well as in both labor and delivery. And the key management principles are to monitor blood sugars and to treat with diet, oral agents, and insulin as needed. Overall, it is rare to have severe hypoglycemia or hyperglycemia with gestational diabetes. Here are the objectives for this presentation. We hope that at the end of this presentation, you're able to perform a clinical history to differentiate different types of diabetes in pregnancy, and to understand the importance of treating blood sugars in each of the trimesters, labor and delivery and postpartum, and to apply these key management priorities of gestational diabetes in pregnancy, labor and delivery and postpartum, with a focus on oral agents, insulin, how to use it and adjust it, as well as the treatment of hypoglycemia. Once again, this is the key reference for this presentation from the Diabetes Canada Clinical Practice Guidelines. Thank you for watching this educational video. If you're from Mount Sinai Hospital, please print out and complete this confirmation of completion, which is available on the website, and give it to the appropriate educational coordinator. Thank you.